over the age of 40 should be getting a mammogram once a year. And whereas it's controversial at times, and there was a recent article that came out stating that perhaps women should not start mammography until in their 50s, the standard of care and the recommendation still remains to start screening mammography. As far as screening breast ultrasound, that is a little controversial. And there's a feeling that in women who are younger or who have dense breast tissue, that screening ultrasound might help in detecting things which mammograms can miss. Certainly when we get older, certainly postmenopausally, probably mammograms are pretty good and will find at least 85% of breast cancers. And so if you're getting mammograms, sometimes there's going to be an abnormality. And sometimes patients will say, or people will talk about having had a mammogram and they see something. Well, what could they possibly see? I don't know. Anyway, what they can possibly see are sometimes lumps and calcifications. And another thing is sometimes there's asymmetry, meaning that we want both breasts, one breast to look like the other. You want the left to look like the right, exactly, but many times they don't. When we have a mammogram, when a patient has a mammogram, and a lump is seen, most of the time a radiologist will recommend that an ultrasound is done. And the ultrasound is done to see whether or not that lump is a cyst, meaning filled with liquid, and usually you don't have to do anything with it, you can just leave it, or solid. And if something is solid, then it usually needs a biopsy. Another time that an ultrasound is indicated is if a patient feels something. And so if you feel something, and even with a negative mammogram, meaning you don't see anything on the mammogram, the patient should get an ultrasound. And probably the best way for the ultrasound to be done is for the patient to have something called a targeted ultrasound, meaning that the radiologist or the radiology tech specifically looks at the area that the patient is feeling. And that's the most accurate way to do it. When the radiologist dictates out their report, what they use is this system called BI-RADS. And BI-RADS is a system where the radiologist is basically telling the healthcare provider what to do with that report. And it goes from obviously 0 to 6, but the 0 means that the patient needs additional imaging. So it may mean that the patient had a mammogram and the radiologist is recommending that the patient have an ultrasound, or perhaps that the patient needs an MRI. What I want to focus on is specifically the BI-RADS 3s and 4s. And so BI-RADS 3, okay, so,
Okay.
whatever. Anyway, trying to be easy here. BI-RADS 3 means that it is, and you're going to get notices in the mail, so you're supposed to legally get a letter about a week or two after you have your mammogram or ultrasound, telling you that the mammogram is either good or to call your healthcare provider. BI-RADS 3 means that the radiologist sees something, but it is probably benign. And that word probably makes everybody crazy, except that probably means that that the radiologist is probably about 95% correct in saying that it is benign. And a BI-RADS 3 means it looks okay, but you need a repeat usually in 6 months. The next one, though, is a BI-RADS 4. BI-RADS 4 means that the patient needs a biopsy, whether or not it's of a lump or calcifications or an area of density. Most BI-RADS 4s, meaning most patients who need a biopsy, whether or not it's with mammogram or ultrasound, most times it's benign, meaning 90% of the needle biopsies that are done turn out to be totally benign. The standard of care, as far as how a patient has to get biopsied, is to be done with a needle biopsy. And so if patients do screening mammography, meaning that they don't feel anything, they're just going for their yearly mammogram, and something is picked up which one cannot feel. Okay.
You're the star. I'm trying to...
I have schmilkes. I just keep on moving.
No,
and
actually,
moving.
you can see if you're in there or not. You'll be able to see yourself.
Is this good?
You can look. You can move wherever you want to be. Just make sure if you see yourself here, you're good. I could just move you.
Got it. Okay.
Just to see yourself.
All right.
You're the star.
Thank you. Okay. Anyway, if you need a biopsy, standard of care, how it should be done, the vast majority of time, is that it should be done with a needle. And it can be done with ultrasound with a needle, or it can be done with a mammogram, with actually something called stereotactic needle biopsy. And that one is, if anybody's ever done it, is where you lie on the table on your belly, and there's a big hole, there's a big opening in the table, and you lean in, and the breast basically falls into this opening, and then the breast is pressed, like a mammogram, and the radiologist is basically under you. So the table goes all the way up, and the radiologist is underneath, and the area is found by computer, and it's within a millimeter. It's very accurate. It's within about a millimeter of the lesion, of the area that has to be biopsied. And the first thing that the radiologist does is they actually numb the area. So everything gets numbed up with Novocaine. And a needle goes in, and basically there's a suction on it, and it sucks out pores of tissue, which are then sent to the pathologist. And so that's the one way, stereotactic core. The different way is ultrasound, and there's aspiration versus core. It's basically the same procedure, it's just that core is a bigger needle. Palpable findings, which I spoke about a little bit before. So if you feel something, so let's say patient says, you know, I feel something, and even if the mammogram shows nothing, and even if the ultrasound as well shows nothing, it still has to be evaluated. We know that all the tests in the world, all put together for breast, mammogram, ultrasound, MRI, nothing is 100%. And so again, I can't stress enough that if you feel something that's different for you, it has to be evaluated by your healthcare person. Most things though...
I know a little bit.
What?
I know a little bit.
Okay. Most cancers, or most benign lesions as well, are picked up either on a mammogram or an ultrasound, but a certain percentage of them are not. You know, one number that always sticks in my head is that in women who are 40, who are diagnosed with breast cancer, 40% of them will actually have a negative mammogram, meaning the mammogram doesn't show anything. And again, many of those women will feel something, and it does have to be evaluated. So what are the possibilities? Most of the time, again, it's benign. Things that we find on mammography or ultrasound are benign. And when the radiologist biopsies anything, whether or not it's on ultrasound or mammography, if it comes back benign, the radiologist as well has to issue a report that says that the lesion itself that you're seeing on x-ray does not look that terrible, and that the findings are concordant, meaning that the mammogram or ultrasound doesn't look bad, and the pathologic findings are benign, and therefore the patient usually gets a 6-month follow-up mammogram or ultrasound. Every now and then, and it does not happen often, the findings are discordant. And what that means is that either mammographically or on ultrasound, the area looks very, very worrisome, and you get back but you get back a benign result on pathology. In those cases, the area probably should be removed surgically to be sure, because there is a sampling error. When somebody has a needle biopsy, there are certain rules, and so benign is benign, great, but every now and then you get back cells which are not normal, abnormal. Did anybody ever see Young Frankenstein? Remember they go abnormal? Yeah. Oh, anyway. Anyway, they're not typical for breast, so They are therefore atypical. And anytime you have atypical cells on a needle biopsy, it has to be excised surgically, meaning that it's an outpatient procedure. It probably takes less than an hour, but the area has to be removed, basically just to get more tissue. The reason why is when you have atypical cells, about 20% of the time, when you remove just that area, there will be something more going on, either a precancer or a cancer. Obviously, the flip side is that 80% of the time, it's still benign, and so the numbers are usually in your favor. Every now and then, though, you get back something called ductal carcinoma in situ. Again, probably less than 10% of the time that we biopsy things. And what that is it's a precancer, it's pre-invasive. We also call it stage 0. It's a good one to have. And most of the time, it's picked up as a small lesion. And the patient usually has the option of a lumpectomy, meaning that the breast stays, and usually followed by radiation. Or they also have the option of a mastectomy. Either way, the patient, survival rate of this one is 98 to 99%. Invasive lesions, basically, that's a broad category of all other cancers, and there are about, 7 or 8 different kinds of breast cancers. Some of them are more or less aggressive. I really don't want to get into the whole management of breast cancer. I just really wanted to talk about what the usual scenario is and what is most likely to happen to women when you go for screening mammography, screening ultrasound. Again, mammography every year. Now, women should be getting it every year, starting at 40. If you have a very, very strong family history of breast cancer, for example, let's say one's mother was diagnosed at 42. You actually, rule of thumb is to start about 10 years before that. So you would start doing screening mammography and probably ultrasound at 32. Just a couple words about the BRCA, the breast cancer gene. In women who are diagnosed less than the age of 50, they probably should be tested for the breast cancer gene. In anyone who has any family history of ovarian cancer or breast cancer in men, or the patient themselves is, again, a first-degree relative being diagnosed less than 50, those patients should be tested. Surgery, again, depending on how large, if someone has cancer or a precancer, depending on how large the lesion is, relative to the size of the breast, those patients can either have a lumpectomy, anyone can have a mastectomy. The question, again, is whether or not a patient is a candidate for a lumpectomy, and there's certain contraindications to it. But what we find is that in a screened population, so in women who go for mammograms regularly, they are more likely to be able to undergo breast conservation, lumpectomy, than in patients who don't. That's actually too much for tonight. If I didn't aggravate anybody too much, then maybe you'll invite me back again. Questions after? That's it.